Allogeneic hematopoietic stem cell transplantation is a very effective method of treatment of acute lymphoblastic leukemia in adults. Its efficacy results from both a chance to use myeloablative conditioning, in particular total body irradiation, and graft versus leukemia reaction. Unfortunately, it is also associated with significant risk of non-relapse mortality, which is in a range of 15 to 20% nowadays. Therefore, in each case, we must weigh potential benefits against harms. So we should take into account both biological and clinical features of the disease and the biological status of the patient. In modern times, treatment paradigms differ significantly for patients with Ph-positive ALL and Ph-negative ALL. In Ph-positive ALL, it is obligatory to start with tyrosine kinase inhibitors as soon as possible, and the intensity of chemotherapy, both induction and consolidation, tends to be reduced. Such a strategy allows for achievement of up to 100% of complete remission, but on the other hand, these remissions are not very stable, and sooner or later, we must be aware of a risk of relapse. So, according to current standards, all patients with Ph-positive ALL should be considered candidates for allogeneic transplantation. This paradigm may change. There are several ongoing or recently completed studies showing that when using upfront second or third generation tyrosine kinase inhibitors, either in combination with chemotherapy or in a sequence with blinatumomab, there may be a chance to achieve cure even without allogeneic transplant. But as for now, we still believe that all patients with Ph-positive ALL should be treated with allogeneic transplantation. In case of Ph-negative ALL, the situation is much more complex. We must identify risks that predict, factors that predict the risk of relapse. And only high-risk patients should be considered for allotransplants. The most commonly accepted factor is response evaluated at the level of minimal residual disease. In details, MRD above 0.1% after induction or detected at any level after consolidation is considered inadequate response at MRD level. So, all these patients should be candidates for allotransplants. Another commonly accepted feature is high leukocyte count at diagnosis. In case of TALL, it is 100 times 10 to the 9, while in case of BALL, it is 30 times 10 to the 9 per liter. Most study groups also consider high-risk karyotype as a factor that should be taken into account when referring patients for allogeneic transplant. And the most commonly accepted high-risk cytogenetic feature is translocation 411 or rearrangements of KMT2A gene. Some other study groups also considered unfavorable immunophenotype or involvement of CNS at diagnosis. So, once again, in each case, we must identify those risk factors, and only high-risk patients should be considered for allogeneic transplants. As in case of Ph-positive ALL, also in Ph-negative ALL, this algorithm may change. There are several studies trying to avoid allogeneic transplant by using upfront chemotherapy in combination or in sequence with blinatumomab, or the use of inotuzumab ozogamicin in combination with chemotherapy. And finally, we also have a perspective of the use of CAR T cells, maybe in case of MRD positivity in first-line treatment. So, I'm very curious about the future. I believe that treatment algorithms within the next decade will change, but so far, approximately 50 to 70% of patients with ALL must be considered candidates for allogeneic transplants. Thank you very much.